this is Kayla Campbell. I'm with Clinical Group 6. My classmates are Maslin Schmitz, Adaria Marks, Shelby Nicholson, Nina McCaw, Perry Fortune, Nia Wells, and Emma Herring. And for this endocrine post conference, we're going to be talking about hyperpituitarism. And so we're going to start with what is this? And so hyperpituitarism is when you have an overactive pituitary gland, and because of this, it releases too much of certain hormones, such as adrenocorticopic hormone, growth hormone, thyroid stimulating hormone, gonadotropins, luteinizing hormone, follicle stimulating hormone, antidiuretic hormone, oxytocin, prolactin, and melanocyte stimulating hormone. And so if you look at this picture that we have over here, it shows what each of these hormones affects. And it shows that melanocyte stimulating hormone coming from the anterior pituitary and affecting the skin. It shows the adrenocorticopic hormone coming from that anterior pituitary and affecting all of the adrenals, and the thyroid coming, the thyroid stimulating hormone coming from the anterior pituitary, affecting the thyroid, obviously, human growth hormone affecting the bone and muscles, gonadotropic hormone affecting the testicles and ovaries, and then that posterior pituitary gland affects oxytocin, which affects breasts, and antidiuretic hormone, which affects your kidneys. And so a overactive pituitary gland, depending on where the cause is, anterior, posterior, it affects these specific hormones. And so overall, there's a disruption in the hypothalamic pituitary axis function, and hyperpituitarism may also be called giantism or acromegaly. Excuse me. So what causes this? A pituitary adenoma, which if you see this little picture on the side right here, it shows a little breakdown of the root words in it, and so it's a gland tumor. So a pituitary adenoma is a tumor that develops in a hormone-producing cell of the pituitary gland. So an overactive pituitary gland is commonly caused by a benign tumor, which is called a pituitary adenoma. It's not exactly known why these tumors occur, but depending on where the tumor forms, in or on the pituitary gland, that anterior or posterior we were talking about, it will secrete more or less of different hormones. Hyperpituitarism can also be caused by genetic inheritance. Family history may indicate that they are at a higher risk for developing this order. So if a family member has had hyperpituitarism in the past, but an individual is more at risk for developing this disease process. Excuse me. So here are some clinical manifestations based on the hormones' specific causes. And so, like we were saying, if that adenoma is on the anterior pituitary gland, growth hormones, thyroid stimulating hormone, and actually all four of these hormones are produced in the anterior pituitary. And so if the tumor is there, you will see these manifestations with these specific hormones. And every case, like case to case, is different. And so you'll see different presentations with each hormone. And so with growth hormone, you're going to see that acromegaly, that thickened, oily skin, thickened lips, deep voice, large head, cardiac, hepatic, and lung enlargement. With the thyroid stimulating hormone, you're going to see weight loss, you're going to see tachycardia, heat intolerance, and fine tremors. With that adrenocorticopic hormone, you're going to see weight gain, truncal obesity, moon face, muscle wasting, decreased bone density, elevated BP. And with the gonadotropin hormones, you're going to see the most common feature is the tumor itself, where you can have elevated luteinizing hormone and follicle stimulating hormone levels. And so, this little picture we have here on this side is actually a great, um, learning tool. And so, it shows the diagnosis. You would look at their growth hormone levels. You'd look in X-ray and MRI, a physical exam, and a history. You'd look at a blood glucose or an oral glucose test, and their levels would not come down. So complications from this hyperpituitary acromegaly, so this is too much human growth hormone. Some complications would be increased intracranial pressure and an enlarged tumor. Obviously, if you've got a big tumor growing in your head, there's not a lot of room for it with your brain inside your skull, so it can cause increased intracranial pressure, and it can also cause increased blood sugar because your adrenals are affected. And so this list of clinical manifestations is actually really useful because you can look at this, so an enlarged pituitary gland, of course, but they're going to have headache, visual disturbances. He has glasses on, slanting forehead. He has a slanting forehead. Protruding jaw. He has a very protruding jaw. Increased blood pressure and congestive heart failure. He has a little heart drawn right here. Menstrual changes, sleep apnea don't exactly apply to this presentation, but enlargement of small bones in the hands and feet. So you see like the extremely large feet and hands, and they have little measuring tapes on them, and so that shows that they're very large. So as the nurse, you're going to want to return hormone levels to normal if possible, but that's a medical management goal as well. You're working as a team to get these levels back to normal. They're going to have, as a nurse, you're going to want to educate on any drug therapy that can be done, which we'll talk about in a second, but it can be done alone or in combination with surgery. And the most common treatment of hyperpituitarism is a surgical removal of the pituitary gland and the tumor, which is called this word, and I'll try and say it, but I'm probably going to butcher it. Hypophyseectomy. So post-op, where nurses have a very, very important job of taking measures to make sure that intracranial pressure is not increased. So we're going to teach the patient to avoid bending over to pick objects, and instead, like, bend their knees, squat down, and pick anything up. We're going to tell them to avoid straining because that can cause an increased intracranial pressure. So that's a high fiber diet, drinking plenty of fluids, and stool softeners or laxatives, because we do not want them straining while having a bowel movement. We're going to teach the patient to avoid coughing early after surgery because it increases pressure in the incision area and may lead to a cerebrospinal fluid leak. And of course, they are not going to be drinking with straws. And so, of course, we're also going to keep the head of the bed elevated, and other things like that. But we do not want that intracranial pressure increased whatsoever. I mean, we learned all about that, and it's not good. So, I'm so sorry, excuse me. How is overactive pituitary treated? And so you treat the underlying cause with a lot of things. That's what you do, and that's what we do here. And so a procedure, a surgery called, I'm going to butcher these words, a transsphenoidal adeno, adenomectomy is usually recommended for patients with acromegaly or Cushing's disease. The surgeon makes a small incision through the nose or upper lip to reach the pituitary and remove the tumor. Although this procedure is very delicate, it has high success rates of greater than 80% when performed by experienced surgeons. Transsephoidal or sephoidal surgery is most effective for small tumors, and so that qualifies as anything under 10 millimeters in diameter. Potential drawbacks include long-term dependence on pituitary hormone replacement therapy and cerebrospinal fluid leakage. Medications may also be used, and so drugs to shrink large tumors before surgery in cases where surgery is not an option. Medication to reduce prolactin levels is usually the preferred treatment for patients with prolactinoma, and so that's one of those hormones that we talked about a little bit ago. With acromegaly, patients with acromegaly may be treated with drugs to lower growth hormone levels and shrink tumors. And so this drug therapy can also be used in combination, excuse me, with surgery. And so they'll use these drugs to shrink tumors before the surgery, and then they will go in and remove it after it is under that 10 millimeter so they don't have to do big old open brain surgery. And so another option is radiation, and it's maybe used to treat patients who cannot undergo surgery, or patients who have residual tumor left after surgery and do not respond to medication. And so there are two approaches to this radiation treatment: conventional and stereotactic. I am so sorry, I've got a cold going on. So conventional radiation therapy is administered in small doses over a period of 4 to 6 weeks. One drawback is that radiation treatments can damage normal tissue surrounding the tumor. Stereotactic therapy provides a high-dose beam of radiation targeted at the tumor. It may be completed in one session, resulting in less damage to the surrounding tissue. Most patients that undergo radiation treatment require hormone replacement therapy due to a gradual decline in the secretion of other pituitary hormones. And so overall, if you have damage to your pituitary gland, you have your pituitary gland removed, you're going to probably be on some kind of hormone replacement therapy, because a lot of these hormones are needed for normal body function and for just to continue living. And so hormone replacement therapy is I would say always done after surgery. And so we are going to teach we're going to teach this patient what to expect regarding the signs and symptoms of this disease process. So it can cause undiagnosed or diagnosed and watching. Hyperpituitarism can cause increased intracranial pressure. And so this pressure can lead to headaches, nausea, vomiting, and any change in level of consciousness in general. That's usually the number one sign, is any kind of change in the level of consciousness. Hyperpituitarism with excess prolactin can lead to symptoms of sexual dysfunction like loss of sex drive. Um, the causes include a malfunction in the pituitary gland, like hyperpituitarism, is most commonly caused by a tumor, and it's usually a pituitary adenoma and is non-cancerous or benign. Teaching also includes teaching any medication um, and all the things they need to look out for on that medication and what they need to call their provider for if they see with that medication. After surgery, we're going to avoid strenuous activities such as bicycle riding, jogging, weightlifting, and aerobic exercise for 1 to 2 weeks. If they had surgery through their skull and not through their nose or lip, try not to lie flat when they rest for 1 to 2 weeks. Let's see. Complications of hyperpituitarism can cause several different conditions, which include the following: Cushing's syndrome, giantism or acromegaly, galactorrhea or prolactinoma, and hyperthyroidism. Complications of hyperpituitarism vary depending on what the condition causes. One possible complication following surgery to remove the tumor is that you're going to need to replace those hormones because they're not being stimulated anymore by that pituitary gland. So 2 fun facts. Harvey Cushing also introduced the terminologies hyperpituitarism and hypopituitarism and described some of their clinical features, including acromegaly, as well as a potential role of neurosurgery in these cases. And so, we already talked about this a lot, but the hormones that are affected, again, they're on that first slide, and it has a really good breakdown of what hormones are secreted in anterior and posterior pituitary gland. And so there are 3 main hormones that have an oversecretion resulting from that pituitary adenoma. So prolactin, adrenocorticopic hormone, and growth hormone. And these are all produced in the anterior pituitary. And we used our Iggy book as a source, and as well as this article from the Cleveland Clinic. And so before I end this, we're going to run through what it is one more time. So hyperpituitarism is an overactive pituitary gland. It's caused by a pituitary adenoma, which is a benign tumor. And depending on where it forms in this anterior or this posterior pituitary gland, we're going to see different changes. So each hormone affects a different something in the body. And so if the adenoma is on the anterior pituitary, you're going to see changes in all of these, in the skin, in the adrenals. So we talked about that pancreas not putting out as much insulin and cause really high blood glucose levels. They're going to have hyperthyroidism, bones and muscles are going to be huge. We talked about big feet, big hands, and it's going to cause dysfunction in their testicles and ovaries. So again, this clinical picture right here is great to think about with hyperpituitarism. And post-op, so the most common medical treatment for hyperpituitarism is surgery, and they're going to get that tumor removed or their whole pituitary gland removed. And post-op, we have to take specific measures not to increase that intracranial pressure. These are just talking about the surgeries and medications again, and we went over that. And so after surgery, that making sure that intracranial pressure is not decreased is a very, very, very important thing. And so we are going to make sure that they're not straining, they keep their head of the bed elevated. And so these complications actually really align with the disease process itself. So the giantism or acromegaly, that's like another word, or that is what that clinical portrait showed. Hyperthyroidism, and so those are directly affected by the oversecretion of hormones in the pituitary. And that is it for hyperpituitarism.